Asha, tell me if I was successful. Do you see my
Yes,
slide?
it looks perfect. Yeah.
Okay. So, you know, that there may not be, there's probably not a right answer to this. It's going to be a process to try to figure out. I'll tell you my approach because this happens quite frequently where people have low level viremia, and so each of us have had to deal with this. I will say most of the time when I've seen low level viremia, it's been a little bit closer to 50 to or 20 to 200, 50 to 200, and this is somewhat higher than that. So I'm kind of nervous about the fact that her last viral load was, I think, in the mid 400s, if I remember right. But nevertheless, between 50 to 200 is a fairly common clinical occurrence. So I think I do essentially what you do. I try to assess adherence. Sometimes I'll call the pharmacy to figure out if they're refilling their meds, but it sounds like this is a person in whom adherence is not a question. Consider drug-drug interactions. You know, obviously integrase inhibitors can be influenced by, absorption can be influenced by multivalent cations that extends not only from calcium, magnesium, iron, but also zinc. And so I consider drug interactions. Remind me, I had it in front of me, but the screens aren't working out. Her current regimen is remind me what it is again, please.
She's on Biktarvy.
Okay. You know, a lot of people have asked, because this happens fairly frequently where people are on a stable regimen, they then switch to bictegravir-taf FTC, and I've seen a couple of occasions where people have low-level viremia. So many people have asked me, and I've asked myself, whether somehow that switch was related, but at least in clinical trials, and we all know that clinical trials are not always reality, but in clinical trials, you don't see a signal, because a lot of those trials are switch studies for a bictegravir-taf FTC. You don't see, you know, obvious low-level viremia, nor do you even see, sometimes they'll look at detectable, undetectable, and you don't see kind of a peaking up of the, you know, the frequency of detectability below 20 or detectability below 50. So at least we haven't seen it, but I too have sometimes noticed when people switch, we've seen low-level viremia. Obviously, an intercurrent illness, back before we had good ARTs, we all knew that viremia was driven up by an intercurrent illness or even by an immunization, but that should be very, very transient, some weeks, not months or longer. Like in this case, this is, I think, years. Malabsorption, I sometimes think about, but it's incredibly rare. It's usually something else. And actually, I failed to mention in that other patient, if that other patient continued to have bacteremia, that's sometimes where I will do therapeutic drug monitoring for mycobacterial drugs. For HIV drugs, I really haven't seen malabsorption as a common cause of failure or low-level viremia. In a particularly unusual circumstance, I might consider drug levels, but it in my own experience hasn't really paid off unless they have kind of other symptoms of malabsorption, and I'm assuming not, otherwise you would have mentioned it. Now, resistance testing you tried to do, I'm imagining you sent, like we all do, a commercial resistance test. If you could prevail upon some of the high-powered researchers there, sometimes you can do resistance testing on lower level viremia in a research laboratory. The commercial assays are usually, you know, need 500 copies, 500 to 1,000 copies, but the research laboratories, you know, can do it. Now, if the viremia is persistent and you really have excluded other possibilities, in recent years, people have been talking about low-level viremia as potentially being due to release of virions from the HIV reservoir without ongoing replication. I suspect many of you are familiar with this paper that John Mellors and his group published last year. This paper is entitled HIV Viremia Not Suppressible by Antiretroviral Therapy, Originating Potentially from Large T-cell Clones Producing Infectious Virus. What they did in the study, this is kind of the background to the study, a slide from Croy from a couple of years ago. So they tried to distinguish productive cycles of viral replication, in which case, if you have ongoing viral replication, you should get different integration sites as a reflection of that ongoing viral replication. So different integration sites and different evolution of HIV sequences. Versus, and this may not still be the model, but cellular or expression of virus from clones may then be manifest with virus that has the same integration site and identical HIV sequences. So this particular paper, they took 8 people, not a large study, 8 people with HIV on long-term ART. The median HIV RNA was in the high 80s with a range, not much above 200 though. The highest viral load was below 200. The median nadir CD4 count was just about the same as this patient's. It was 212. I think this patient was in the low 200s. First, they looked for drug resistance, couldn't find any. They looked for drug concentrations. They were all in the therapeutic range. Then did sequencing, and they found that over time, and many of these people had been low-level viremic for years, they found no evidence of change in the RNA sequence, and they did not evolve any drug resistance. In 4 of the donors, the plasma viral sequence matched sequences from virus outgrowth assays, arguing that it was replication competent. And then when they did an integration site analysis, they had evidence of identical integration sites suggesting a clonal origin of plasma viremia. And the implication is that in these instances, and I have a few patients like this myself, that changing or intensifying ART really would not be effective. It's just virion production from the reservoir. Now, I would say Bob and Janet Silicano wrote this nice editorial that goes alongside this paper. The title of their editorial is here, the non-suppressible viremia, a reflection of how the reservoir persists. I told Natasha that phylogenetic trees always confuse me. So the phylogenetic trees are in the paper, but I like their illustration even better. This is in the Mellor's paper, this is Silicano's illustration. So you see that over time, you can get expansion of different clones, and in this instance, the clones are what are probably leading to the non-suppressible viremia. So this kind of visual illustration, I think, makes it easier to understand. Now, many years before, actually, this recognition, Justin Bailey, who I looked at, Bob and Janet, did this study. And this actually is the same principle. Everyone has some amount of residual low-level viremia. And what I found really important about this study, and Bob, you or Janet should comment, but the abstract from this said, despite the large diversity of pulse sequences, that they were looking at what they eventually called the predominant plasma clone, that despite the diversity of pulse sequences in resting CD4 cells, the residual viremia was dominated by a homogeneous population of viruses with identical pulse sequences. This persisted for years. And so their conclusion essentially is that the major mechanism for residual viremia, these were, I think, generally below 50 copies, involves prolonged production of a small number of viral clones without evident evolution. So this concept has been around for a long time. It's just that what we're seeing clinically sometimes are people whose reservoir is such that they have non-suppressible viremia above our threshold of clinical detection. So it's possible that that's what you're seeing here, although I am a little concerned about the viral load of being above 400. That was kind of, concerning. So I will stop there. I would love it if someone else wants to comment on this.
We have a fair amount of co-authors and the Silicanos here, so it would be wonderful.
So Raj, thanks for beautiful explanation. So just want to point out that Francesco Simonetti, who's here, actually a PhD student, but is an ID physician from Italy, has beautifully shown that this proliferation of latently infected cells is actually driven by antigen. And so is essentially part of the normal immune response. He looked at infected cells that were specific for CMV, but carried an HIV provirus. And these clones responding to CMV can get to be very, very large and can, in some cases, produce virus contributing to this non-suppressible viremia. And the disturbing thing, I think, is that this is a process that's maintaining the reservoir and involves proliferation of infected cells, expanding the reservoir without any real de novo infection. And it's going to be hard to block this because it's basically, part of the normal way that the T cells respond.
Would you agree that it probably clinically, as long as people are monitoring it carefully, and as long as you rule out more ominous reasons for virologic failure, it probably reflects the reservoir's persistence, but is not likely to hurt the the individual person.
Right. It's just in terms of cure where it's the issue. It's not, I guess, a clinical issue, but in terms of cure.
Yeah, so if you can rule out some of the other causes, you know, resistance, I guess, is unlikely. So it's really adherence and things like drug-drug interactions. And my sense is you've already done that, and just watch that viral load, especially since it's about 200.
So like, Eileen, could you ask your question verbally so folks can hear who in the chat?
Right, so I'd just be fascinated if Raj and Bob or Janet had thoughts about whether or not you thought this was one of her autoimmune clones, like, because autoimmune hepatitis in particular, I think is usually T-cell driven. I don't remember exactly if it tracked with her disease status or if there were any other ways that you would see that type of connection.
You know, I looked up in advance to try to see if I could figure out one of the drugs she had gotten. She'd gotten TNF inhibitors, she'd gotten azathioprine, she'd gotten cyclosporin. You know, all of these have actually at different times been studied to try to affect, you know, inflammation, to try to affect reservoir. But I could not personally figure out a connection other than maybe more speculatively what you said is that maybe that allowed it, clones to outgrow. I don't know. I would look, let's see what Janet, I think Janet, you're preparing to say something.
Well, that's possible, I think, Eileen. Francesco Simonetti's original description of an expanded clone was a tumor-specific clone. And his recent JCI paper showed patients with CMV-specific large clones. I mean, these clones can get to be at least 10 to the 8th. You know, in size, so they're very large. So I think your comment, I mean, is could be for sure.
Yeah, I might ask you all to explain this to the patient when she comes to clinic. Well, or poor Sonia can do.
Just show her the picture.
Yeah, this is you. And then I guess, I mean, and probably we don't have enough people to actually know this yet, but is there any concern that, you know, even though it's low level, that this might promote inflammation and, you know, concerns around comorbidity related to inflammation like cardiovascular illness and whatnot?
You know, I would say if this is a release of virus as opposed to replication, which is what I think it is, then I'm not convinced that it is driving inflammation. Now, I am firmly convinced that there's a legacy effect. We have some data that we've published that says that if you start off with a, you know, low CD4 count, now this person's CD4 count was in the low 200s, but there is probably an inflammatory legacy effect. But I'm not convinced that it's the virus right now, if it's just originating from the reservoir that's driving it, as long as there's not replication. I think, you know, if we rule out the other causes, I think that the likelihood that this is replicating virus is relatively low.
Well, so I know we also,
yeah, so there's an inflammatory legacy effect. I think they are probably at risk for some amount of, you know, the things associated with inflammation, but I'm not sure it's directly linked to the virus.
Okay, great. Well, we also have some discussion around COVID and HIV that I do want to make sure we can get to. So Sonia, thank you so much for presenting this case again in the midst of all your master's classes. There's a couple great questions in the chat if other folks want to answer those, but I want to make sure we can get to some of the discussion on COVID and HIV.
And if you do find out more about this patient, definitely share with all of us, but including me. So.
Great.
All right. Because of time, I think what I will do is not, I want to try to do two things in the last 10 minutes or so. Or 15 minutes, I'll try to adjust the time accordingly. I'll talk a little bit about HIV and COVID because I think there are some new data that are worth reflecting on, because this has been a, you know, kind of an evolving topic over the last year. And then I do want to, at the very end, talk about HIV-MA a little bit, HIV Medicine Association, and just, you know, highlight that because Hopkins has a very long tradition, including to this date, of firm involvement with IDSA. And I think I was talking to someone who didn't quite realize that HIV-MA is part of IDSA, and I wanted to make sure that everyone kind of knew the connection. So this will be short. These are the known risk factors for severe COVID-19. On your left is known risk factors. On your right are potential risk factors. This was as of about 2 weeks ago, but the CDC has just updated their list of risk factors for severe COVID-19 about a week ago. And HIV used to be on the right-hand side of your slide. on other immunocompromised states, it's now shifted over towards the left-hand side. And that's because of some data that has come in over the last 6 months. A couple of potential reasons why people with HIV may have worse outcomes. Immune deficiency, we know organ transplant recipients are at increased risk for severe COVID. We know that prolonged SARS-CoV-2 replication has been reported in immunocompromised hosts. I know you've all seen that. There has been some suggestions from the very beginning of COVID that people with HIV with low CD4 counts may have increased risk for severe COVID, as they do have for influenza. One thing that has not been proven, but we were just talking about inflammation a second ago. We are convinced that there is residual inflammation in people with HIV on ART, particularly if they had a low CD4 count nadir, particularly if they had incomplete CD4 reconstitution or a low CD4 to CD8 ratio. I wonder if there's an impact on COVID that has not been shown yet. I think it's something that's definitely worth studying as to whether that immune dysregulation in HIV affects COVID. Perhaps most importantly, though, people with HIV have a variety of comorbidities that place them at risk for severe COVID-19, and can't escape the fact that because of social determinants of health, that people with HIV are more likely to be racial and ethnic minorities, to be poor, and these are clear-cut risk factors for worse COVID-19 outcomes. This came home to me personally in a case series that we published last March, April. This was our first 50 or so people with HIV who had confirmed COVID. 36 had confirmed COVID, 11 had probable infection. But what was striking to us is at that time, and this has now become quite apparent, is that 83% of them had a non-HIV comorbidity associated with severe COVID, such as obesity and CVD. Our clinic is about 40% Black Latinx. 80% of our patients with COVID and HIV were Black Latinx. And interestingly, about 50% either lived in a congregate setting or worked in a congregate setting. Now, Jean Triant and I had published an editorial on this topic not too long ago. It's January, which I guess is some time ago now. At that time, the early studies on HIV and COVID, some of which are summarized here, which I won't go through, suggested there was probably not a link between HIV and COVID outcomes. But most recently, I would say that some larger cohort studies from New York City, from the UK, from South Africa, have supported some association between HIV and COVID. And the question is why? Is it comorbidities? Is it social determinants? Is it HIV itself? Now, this is a study that Jing Sun from Hopkins presented at CROI this year. I think it's an important study. It looks at 500,000 people with COVID-19. The primary outcomes were hospitalization and mechanical ventilation. And you can see on the graphic on the right that people with HIV, as well as people with solid organ transplants, had greater rates of hospitalization and mechanical ventilation. And they did attempt to adjust for comorbidities. A lot of that hospitalization was driven in part by high burdens of comorbidities, but they found what they think to be an independent effect. What they don't have good data on is what were the people with HIV? Were they on ART? Were they CD4 reconstituted? And those kind of things we don't have data on. Now, other studies which are smaller have associated low CD4 count with worse outcomes, but they're often single arm studies. So this is a without the numbers to clearly adjust for all the comorbidities. So this is a University of Missouri cohort from a lot of different US sites. I wouldn't be surprised if you might have contributed patients to this. And I'm pretty sure folks at Hopkins are organizing a larger cohort, or maybe have organized a larger cohort. In this particular study, one of the correlates of worse COVID outcomes was low CD4 count. A study out of Europe had a largely similar finding that people with HIV with a CD4 count less than 350 had worse outcomes. So this is my take as of now, and I've been deliberately brief because of the time constraints. I do think there are an increasing number of studies suggesting that people with HIV have worse outcomes. We still could benefit from more definitive studies accounting for the immunologic function, comorbidities, socioeconomic disparities. I do think our editorial argued that people with HIV should be prioritized for vaccination, and essentially last week, the CDC put HIV in the same category as other medical comorbidities, so-called phase 1C, that qualify for COVID vaccination. Hopefully this will be all moved as soon as our supply gets better. So those were my comments on HIV and COVID. I could probably go on forever if you would like, but I can also transition to yeah. I had heard that Annie Antar is doing the MFAR study, and I think one of the people at our site was going to contribute to Annie's study, contribute some of our patients to that cohort. So.
Hi all, this is Greg.
Yeah.
I just wanted to say Jing, I think, is actually on the call as well. And in the N3C collaborative, which really has hundreds of thousands of patients, and we're able to get 10,000 or so of the HIV positive patients with COVID, Jing demonstrates a really nice adjusting for sort of demographic factors, attenuates this fourfold risk. Then you adjust for other comorbidities, it attenuates the risk, but there still is persistent risk.
Yes.
The data comes from academic medical centers primarily all around the country. It's one of the largest studies. Everyone is almost all on ART. The problem is our CD4 and viral load data has been really difficult to clean. So we're trying to work on that. But essentially, you should assume that most of those people, although they have comorbidities, they likely they're on ART and probably are virally suppressed. So it's probably not too much signal related to virus. The CD4 data has really been all over the map and very difficult to clean.
Yeah, the CD4 count data would I be most interested. I'm not surprised that most people are on ART, but knowing whether there's a gradient across CD4, either nadirs or CD4 count current or reconstituted CD4 cells, I think really would be an important contribution. So if there's a way to nail that down, I think that would be great.
Dean spent countless hours trying to go.
Yes, I can imagine.
We won't get nadir, but we should get current CD4.
Great. Look forward to seeing it. Natasha, last 5 minutes on HIV/MA or any other question or comments?
I think that Bob, were you going to say something? No? Okay, sorry.
Okay.
Great. Let's do HIV/MA.
So this year I've been honored to be the chair of HIV/MA. I think many of you know its work, but I wanted to share with you a little bit about it because IDSA went through a strategic reprioritization a couple of years ago, and HIV/MA has just completed its strategic vision. The vision, of course, of all of us is to end the HIV epidemic. That is the guidepost for all of us. But just as a focus, the strategic priorities are really of HIV/MA to sustain and build a robust, diverse, and culturally competent HIV workforce. And I'm going to show you a couple of initiatives on that regard in just a moment. And then the other focus of HIV/MA is to increase access to healthcare services and coverage for populations at risk for HIV, as well as for people with HIV. COVID highlights that dramatically, but this has always been the issue, as all of you know well, for HIV. So some examples of recent initiatives, and a couple of these I want to ask for your help with, but this one in particular. So the late John Lewis from Georgia introduced this bill before he passed away. Through the advocacy of HIV/MA and a person named Melanie Thompson, who at the time was the chair of HIV/MA, and this is the HELP Act. This is a HIV epidemic loan repayment program, essentially for HIV clinicians and dentists in Ryan-wide clinics. The bill would provide up to $250,000 in loan repayment for people working in those areas for up to 5 years of service. Through HIV/MA's advocacy, and this links back to the workforce. This has been reintroduced by a number of members of the House of Representatives shown on this particular slide. And HIV/MA now is is advocating for more co-sponsors. I did this the other night. It literally takes less than 1 minute. It's on the HIV/MA site to write your representative to advocate for more co-sponsors for this for the HELP Act. And so this is in the category of workforce sustenance, workforce replenishment. HIV/MA also spends a lot of time focusing on providing resources for HIV clinicians. One of the most recent ones is this very nice guideline that came out just last November that many of you have probably seen, primary care guidance. It had been updated from one that had been quite out of date. I'll give you a few other examples. This is just to get a flavor of what HIV/MA does. Most recently, they've published what I think to be good resources around considerations for people with HIV around the issue of COVID. Much of the information that all of us use in clinic are really pulled together in a nice form in this particular guidance. HAVMA also works closely with the DHHS panel, which also has a good section on COVID-19 and people with HIV. I'm interested, we probably won't have time today to hear about your own experience with long-acting antiretroviral therapy and how you're setting up cabotegravir, rilpivirine. NASTAD, which is a really good organization that works on issues of cost, HAVMA and the American Academy of HIV Medicine have put together a nice brief that I've circulated to our clinic to pull together some of the issues around preparing for long-acting ART. This was issued just before the approval for cabotegravir, rilpivirine, but I think serves as a nice foundation, and now we're building on it. In fact, some of our recent meetings are now trying to operationalize this, and maybe I can get a consult from some of the folks in your clinic to see how you're all doing it. This is support for HIV clinicians around the vaccines, frequently asked questions that I think has been updated since March after the Janssen vaccine got authorized. And then last, switching to access to care. This will be my second to last slide. Two examples of what HAVMA has been doing around advocacy for access to care. One is Wendy Armstrong, who probably many of you know at Emory, wrote a nice article with colleagues on innovations in HIV care delivery during COVID-19, things around telehealth, things around other things that we want to sustain after COVID-19. And then IDSA and HAVMA has really focused appropriately on infectious complications of substance use disorder. And so there's a nice co-sponsored advocacy agenda. So that's a long-winded way to say, I went the wrong way. As you know, IDSA is soliciting for new boards of directors, but so is HAVMA, and you all have, I think it's till the 16th. So if you're interested, please do apply. And you know, the strength of HAVMA is the strength of its membership and its board. And so this is an application for board membership that I think is due sometime next week. So that's it. So we got
a lot of thank yous and accolades in the chat, Raj, if you want to spend an hour or so reviewing. But thank you so much for taking the time to visit us today.
It was such a pleasure to be back. I did ask, maybe I'll, if you haven't taken a picture, I would love it if you would, because you probably know how to take a picture, and I would love to get a group photo.
Yeah.
So.
Yeah, I've been taking some, but you know, no one's looking at the camera. So if folks could just look at the camera, there's a lot of
everyone can turn their cameras on first. So.
Yes.
Dave, so good to see.
Dave is requesting.
Thanks,
oh, see, look, people listen to you, and I say no, doesn't.
Get a better picture.
Wonderful. Okay, so I'm going to count down to give folks more time to turn on if they wish. So we'll say 5, 4, 3, 2, 1. That's the most we've had ever with cameras on. I really have to say.
Well, but when Dave Thomas talks, people listen. So good.
Yeah. A quiet.
Thank you so much, Raj. Thanks, Raj. This is really wonderful. Thank you.
Great to see you all. Look forward to seeing much more of you over the coming months and years. So.
Yes.
Take care. Thank you.
Thanks, Raj.
Thank you. Thanks, everyone.
Bye.
Bye. Thank you, Raj.
Take care, Jimmy. See you.